Hey guys, my name is Callie. I wanted to take a quick moment to introduce myself and to give you a little bit of my background so you know I know a little bit about what I'm talking about today. I am a triple board certified critical care nurse. What I mean by that is I hold a CEN, a CCRN, and a CFRN. And I've been doing this about 5.5 years now. I started out as a floor nurse and an ICU nurse combo, and from there I transitioned to the ER. So I know what that floor nurse life is like. I moved to the ER from there and worked in a trauma ER, a busy level 1 trauma center in Atlanta, ran a trauma bay. After a period of time there, I realized I could keep anyone alive, but I had no technical skills. So I then picked the most technical ICU I could think of and bridged over to CVICU. There I learned how to run ECMO, balloon pumps, and pellets. That hospital then created its own rapid response team. I jumped on that opportunity to become a rapid response nurse and became the youngest one on the team. I then was asked to join another rapid response team at a local hospital and got advanced credentialed and trained to RSI and intubate patients, which was super cool. Not to say I'm proficient by any means, but it definitely expanded my knowledge base and my scope of practice. Well, for that hospital system. I then got burned out. I was working about 3 jobs at one time to pay my bills, and I wasn't particularly set on where I was living, so I decided to travel nurse, which leads me to why we're here today. I picked up a gig in Baltimore, which has been hit pretty decently hard with the COVID, as I call it, I guess. Not as hard as New York by any means, but I've definitely trained, 8 to 10 IMC and floor nurses in the past few weeks on how to be an ICU nurse in a day. So I wanted to kind of go over with you guys my spiel on how to be an ICU nurse in a day. I can't teach experience. That is the one caveat to this. The ones who have done the best are the ones who have had several years of IMC experience or floor nurse experience and have kind of seen what patients look like when they're sick and are pretty competent with all those basic skills. And then all they have to do is learn a few bridge ICU skills. But this will help anyone out as they're entering an ICU entirely overwhelmed. So there's 3 main things with these COVID patients that are going to be important to know about, or at least kind of have a base understanding. It's your ventilator, your sedation to keep them asleep on the ventilator, and then your vasopressors, which normally you have to run because the sedation drops your blood pressure. So your ventilator, we'll talk about that one. As a nurse, there are about 2 buttons we can press on this ventilator. There is an 100% FiO2 button and a silence button. The 100% FiO2 button gives them 100% oxygen for a set period of time. Usually you have to push it in and hold it for a second, and it'll give them like 30 seconds or a minute or so of 100% oxygen. We use this button before suctioning the patient. We use this button if they're desatting for some reason. And then I've been using it just anytime I go in to disturb the patient. Some of these COVID patients are so sick, they'll cough. They'll not even be awake. They'll just cough, and their sats will go from 90% to 70%. And it'll take a hot minute for them to come back up. So this is a button I've been using liberally, especially on those that desat with any type of movement. So if I'm going to turn the patient, bathe the patient, anything like that, even oral care, I'll give them 100% FiO2, do the thing, probably give them 100% FiO2 a few more times, and then hopefully they'll be able to stabilize their oxygen demands. Your other button is that silence button. As a new ICU nurse, because you are now, I say use this button sparingly, which seems counterintuitive. But if you don't know why your vent is alarming, if you don't know how to read that screen and all the things on it yet, you're probably going to need help if your event is alarming. So if you silence that button the moment it alarms, no one's coming to rescue you. In an ICU, people will come to rescue you. So we might ignore it for a few seconds if that event is going off, thinking you haven't pressed the silence button yet. But if it keeps alarming and alarming, you'll see more and more and more people showing up to your room to help you out and figure out what's going on. The vent is a life-saving device, and if it's alarming, there's something going on that's not providing oxygen to the patient, and it's something important to handle right away. So use that silence button sparingly unless you're, say, suctioning your patient. They start coughing. That'll create high pressure alarms. The ventral alarm, you can silence it so they go back to sleep and they're not hearing all that noise waking them up. If they start coughing, that should go away. It should resolve the alarm. Other than that, if you don't know why it's alarming, hold off on pressing that button unless you have someone experienced with you, is my recommendation. There's two more important things to know about your vent. One is the type of vent setting, and the other is, I guess, all your vent settings. Where to read your vent settings. I don't expect you guys to know. I did not learn. It took me a hot minute to learn all the types of vent settings and what they mean, and I'm still learning things every day. So there's too much to learn in a day. But just asking in report or your RT or whoever what type of vent setting you're on. If you're on a continuous mechanical ventilation, a mode where the patient isn't supposed to breathe over. If they're on like a pressure support or a CPAP mode where the patient is responsible for creating the respiratory rate, for pulling their own breaths with some support. Or if they're somewhere in between like an SIMV mode where they have a set amount of breaths, but they can breathe over. It's important to note, this also gives you an idea as to how sick your patient is or how close they are to weaning the vent. The CMV modes, the continuous mechanical ventilation modes, are the ones that don't allow them to breathe over. Those are ones for patients that aren't awake and that need to be highly sedated. If they're in like a pressure support or a CPAP mode and they're supposed to be pulling their own volumes, normally that's a patient that's not as highly sedated and they're closer to getting extubated. Just kind of something good to know. The other thing is where to see your vent settings. They should be on the front of your ventilator. Now, don't be afraid to ask the off-going shift or your charge nurse or whoever where to find your buttons, your silence button, your 100% FiO2 button, and where all those vent settings are listed. We are seeing all types of vents with this COVID thing. I have had old vents, new vents, transport vents in my rooms, and even myself have had to be like, where are the settings? Where do I see where am I seeing where my patient is breathing? Where am I seeing the set rate? Just ask. We, as ICU nurses, we prefer if you ask. I think more highly of people if they ask questions more than if they pretend they know what they're doing. Side note. So somewhere on there, you will see your patient settings, what their FiO2 is set at. You'll know if you're maxed out. If you're on 100% FiO2, you don't have much else places to go. You'll know what your PEEP is set at, your positive and expiratory pressure. You'll know if you have a set respiratory rate. All these things are kind of important, at least to start keeping in the back of your mind. So your ventilators, you have two buttons, your silence button, your FiO2 button, and you want to know where your vent settings are listed and what type of mode. Even if you don't know what all that means yet, it's important. And you'll learn more as you go. So that covers your ventilator. Your sedation, the thing that keeps your patient on the ventilator. Technically, some patients will tolerate a ventilator while being awake. It doesn't have to be the end of the world. COVID patients are not those patients. 98% of them are not those patients. We are having to use more sedation for these people than we normally have to use, because if they are so sick, if they're using any increased oxygen demands by coughing, by waking up and thrashing around, or just waking up and as you turn them, they're tanking their oxygen sats and they're not doing well. So sedation is super important. There's many drugs that you're going to see being used for sedation. And these are potent. A lot of these will relax the blood vessels, and some of them will actually decrease your cardiac output. So you'll see drops in your blood pressure. You'll see drops in your heart rate. You'll see drops, those two mostly. Sometimes even in your perfusion. Your patients can get cold. It's very interesting. The main types of sedation we've been using, there aren't main types of sedation we've been throwing everything at people, and we're running out of sedation now. I don't know if you've heard about it or if that's where you're at in your world right now, but we have like a fentanyl shortage, so we're trying other things other than the fentanyl. But your main sedation drugs are propofol. It's that milky white substance. It's lipid based. Ketamine. It's highly hallucinogenic. There is Versed, which has an amnesic effect. Your patient more or less should forget things. There's fentanyl, which is a narcotic. It actually is really helpful with sedation. And then Precedex is another one that we use. I will provide a link, a PDF for your basic information on these. The best thing I can say about sedation is when you're getting a report, find out obviously what they're on, if they have any boluses, and how sedated we're keeping them, their RASCAL. If we're trying to keep them like very close to a coma where they don't hardly respond to any stimuli, if we are keeping them to where they're sleeping, but if you come in there and stimulate them, they might wake up enough to squeeze your hands, or where we're keeping them at, and what they've done with the sedation that day. So if we've been weaning it down, have we had to increase it? The other word I will say on sedation, propofol is better if it's the icing on the cake. This is my analogy. We use these things in layers is the best way to use them. So the way I like to do it is I like to have like a base of fentanyl, like 150, 200, 250 of fentanyl, although we're running out now. Then Versed on top of that. Even just those two, that in the ER world counts as a conscious sedation. So then some Versed on top of that, which are also great things if your patient's waking up to be able to just bolus. Then, if you're trying to keep your patient even more asleep, run some propofol on top of that. What I've seen as a problem with some of these patients is they require so much sedation. We've been running these propofol at really high levels, and then their triglycerides shoot up, and they can almost get some type of propofol infusion syndrome, really sick from having too much propofol. But if you're using it in a layering effect, you're not going to run into that right away. You're not going to create a toxicity with your propofol. That's my word on sedation. What are you using? Where have you been at? Has it dropped their blood pressure or heart rate at all? And what's your RASCAL you're going for? The third part of ICU nursing in a day that you're going to learn about is vasopressors. So some of these patients have a robust blood pressure and don't necessarily need a vasopressor, something to keep their blood pressure up. Partially from the sepsis reaction, partially from the sedation. A lot of these patients do need something to keep their blood pressure up. The most common one you'll see is Levophed. Norepinephrine is the other name for that. This is a great base vasopressor. It increases the contractility of the heart a little bit. It increases, your blood vessels contraction a little bit, and it also increases your heart rate a little bit. That's a great one to use. What you need to know about your Levophed or your norepinephrine is it weight-based or is it not weight-based? And what your concentration is. This is where ICU nursing gets terrible. There are different concentrations that we use. You can have 4 in 250. You can be using 8 milligrams in 250. You can go up to 16 milligrams in 250. Just knowing which one you're using, because you have to program that into the pump correctly, or else bad things can happen to your patient. You may be running like half of what you thought you were or double what you thought you were. So knowing what your concentration is, and then where they've been at for the day. Again, just like the sedation. Have you had to go way up on the Levophed today? If you're having to go way up on a blood pressure medicine, something to keep their blood pressure up, that might be a sign that something's going on with your patient. Now, if it completely correlates with all the sedation, like you added a ton of sedation and then you had to go right up on that Levophed, that makes sense. But if you've been going up for no reason, it's not for no reason. That's something to let the doctor know about. There's a couple other vasopressors you might see. A less common one is neosynephrine. I'm not a big fan of that one. It doesn't increase your heart rate that much. It just tightens up those blood vessels, but that also in turn can increase the workload of the heart. Epinephrine is another one. We see that one in codes, right? You might be familiar with that one. It's a decent one, but it does have more of an affinity for increasing your heart rate. So that's going to increase the heart rate more. It increases the contractility of the heart more than Levophed will. So it might be used for heart patients a little more. And then it also will clamp down your blood vessels. Levoped's a great base vasopressor. So just knowing what your vasopressors are, what ranges they've been in, and if they've been going up or down on them. And then if they're weight-based or not weight-based. That's my main points on your vasopressors. And I will provide, like I said, I'll provide a PDF or a link below on some of the best things to know about these vasopressors. That is pretty much how to be an ICU nurse in a day. Just asking these questions, knowing what setting knowing about your ventilator, what setting they're on, what mode they're on, and then your 2 buttons you can press, knowing how you're keeping your patient asleep, what meds you've been using, and if you've been having to go up and down, and how asleep you're keeping your patient, that RASS score, the agitation score, and what the patient has been able to do, or have they been waking up and desatting, might need a little more sedation, especially if they're desatting to the 70s, like some of these COVID patients. And then the third one, your vasopressors. Do you have anything in line to keep your patient's blood pressure up? And if so, what is it? I think that's about all my pearls for today. I hope you guys are doing well with your COVID nursing, and that this helps you out as you transition from either an ER nurse, a PACU nurse, floor nurse, IMC nurse, and become an ICU nurse in a day. Good luck, guys.